So, welcome everybody. It's our great pleasure to kind of continue our series of continuous medical education provided by the Sudanese psychiatrist. We've started this series almost about a year ago, and every time we've been hosting like one of the pioneers in the field in order to kind of provide to us more of an overview about their area of interest and expertise. And today we have the pleasure to have to host Dr. Ghaemi, Nassir Ghaemi. And Dr. Nassir Ghaemi, if I've been like really interested in reading his kind of articles, publications since residency. Like, I mean, he has his unique way of writing things. And just an overview about his accomplishment. Dr. Ghaemi started his career in psychiatry. It started with a progressive, great, steady progress. He earned his medical degree from the University of Virginia and psychiatry residency at Harvard Medical School at McLean Hospital program in 1994. Later on, he did research fellowship in mood disorders at M.P.H. He then returned to Virginia Commonwealth University to work as an assistant professor, where he worked there, and then he moved around to Georgetown University as well as George Washington University to work at the same capacity as an assistant professor. He then joined back Harvard Medical School to work as an assistant professor and worked also for the Cambridge Hospital. He later on served as an associate professor at Emory University. And since 2008, he has held a position as a full professor of psychiatry at Tufts University, while also lecturing on psychiatry at Harvard Medical School. In addition to this, he obtained an MA in philosophy from Tufts University in 2001 and M.P.H from Harvard University School of Public Health in 2004. He's currently the director of Mood Disorder Program and Psychopharmacology Consultation Clinic at Tufts University, Tufts Medical Center, and a full professor at Tufts University School of Medicine. Dr. Ghaemi's clinical work and research have focused on depression and manic depressive illness, particularly exploring the role of antidepressants in the treatment of bipolar disorder. He has published more than 300 scientific papers, and his publications have been featured. Actually, even his work has been featured. He's been featured on the CNN, MSNBC, as well as other major media. He authored several books, and several of his books has been especially like The First Rate Madness was a national bestseller and was reviewed by Wall Street Journal, New York Times, Washington Post, and elsewhere. He has a lot, he's currently has a podcast, and I'm encouraging everybody to kind of join the podcast to listen to him, where he frequently talk about important areas in the field and several publications in the field too. And without further ado, I welcome Dr. Ghaemi to talk about his topic today, which is why the DSM is mostly false. Before we start the discussion today, I'm asking everybody to put them to silence themselves, and later on we'll open the chance for questions at the end.
Thank you, Yasser, for that introduction. Thank you for inviting me. I know we have some colleagues in Africa who have logged in, so I appreciate you all joining, and I hope we have a little time for discussion, and that this will be of interest to you. As we discussed topics, we decided to pick the topic of DSM and my critique of DSM for today's discussion. My general view on DSM is that it's mostly false, as the title says, and that's not a controversial comment in my view. I'm going to show you that it's factually quite simple to show, and it is shown by describing the fact that DSM is not validated. It does not have validation for most of its diagnoses. It has reliability, but not validation. And that's the basic idea for the talk, and I'll try to explain that for you, describe to you how it came about, describe some of its consequences and implications, and talk about potential solutions as well. Okay, so let me go forward here. Some sources, some historians noted here have really been able to provide some of the details for a lot of what I'm going to describe to you. Now, before DSM-3 in 1980, there were two other versions that were not used much, and really the ICD system was used more for insurance purposes. It still is used for insurance purposes in the West. And that ultimately is the only real rationale for any kind of system like this is to have an insurance checklist. But we don't need DSM. We could still use ICD for insurance and otherwise and not use and have any DSM at all. There is no other discipline in medicine, no other specialty that has a DSM. This is worth emphasizing. I think psychiatrists often live in a silo. They don't understand how the rest of medicine works. Nobody else has their main professional organization sit down and list all the criteria for all possible diagnoses and force all doctors to diagnose only that way. Only psychiatry does that. What do other doctors do, you might ask? Well, they just follow the research in the journals and they follow the textbooks. They don't have the American Medical Association describing every internal medicine diagnosis and all of its features and criteria and forcing all doctors to prescribe only that way. Otherwise, they would have malpractice lawsuits or other problems. So psychiatry in its DSM is actually very unmedical. A lot of people will say it's the medical model. It's not the medical model at all. The medical model is anti-DSM. There's no DSM in the medical model. The other another basic point to make about DSM is that its criteria are not primarily based on science or research. The DSM-4 leaders admitted this. They say it's based on pragmatism, by which they mean that the leadership of the DSM committees make these decisions in a utilitarian way, which means what do they think is most useful for the society and for the profession? Well, that has no basis necessarily in scientific studies or research studies. Sometimes they decide that what's useful is the opposite of what the scientific and research studies show. So they actually become anti-scientific, which we'll describe examples of. Well, if you make your decisions based on utilitarian factors, then that is exactly what is meant by the concept of a social construction. The social construction is the idea that there's not really a truth or a reality, but rather society or groups of people in society come together to have a consensus to think about things a certain kind of way. That's the way postmodernist philosophy has viewed all claims to truth, including scientific truth. It's also the way people view, for instance, religious truths. There's no necessarily truth about anything, proof about anything. It's just different social beliefs. That has been claimed about society as well. And that would be one way of describing what DSM is. DSM is a social construction. It's literally a group of people sitting around a committee table in the United States describing what they feel people should do. It's not based on research, data, proof of any kind. So we get to the issue of how you could know whether it's true. And that's the concept of validity. Validity means that the diagnosis is true in some kind of way. It's either a biological reality, a psychological reality, and then you might ask, well, what's reality? Which gets back to that point of social construction. One perspective here is that there's something real in the external world that's not just based on a social construction. It's not just based on what a group of committee members around the table think, but it actually exists on its own. Well, how can you know that? How can you know something is valid? Can you base it on symptoms? Can we say that a diagnosis is valid just based on its symptoms? And the answer is no. The answer in general medicine has been known to be no for over a century because different symptoms can represent different diseases, and the same symptoms can represent different diseases, and different symptoms can represent the same disease. Therefore, whether your symptoms are the same or different has no bearing on whether they reflect one disease or a different disease. You can't identify diagnoses as reflection of possible diseases just based on symptoms. That's a basic fact of medicine. And yet all of DSM is symptoms. And then the clinicians debate the symptoms. Oh, these mood swings, are they bipolar or borderline? Well, it's a waste of time because symptoms won't tell you. Well, if you can't use symptoms, how can you know if diseases are valid? How can you tell if you have diseases? Well, you need an independent line of evidence other than symptoms. What is it in medicine? It's pathology. It's looking at autopsy, tissue from a biopsy, and laboratory tests sometimes. Not always, though. You don't always have pathology. There's no pathological diagnosis of migraine or epilepsy. Um, However, in psychiatry, we never have pathology, and that's our problem. So, since we don't have pathology, what would the independent line of evidence be to validate symptoms in psychiatry? Well, about 50 years ago, before DSM-3, the groups that were doing a lot of research on this and developed what was called research diagnostic criteria or validity in psychiatry, they suggested that the other validators could be, and this is just a modern adaptation of it, family history or genetics, the course of the illness, and biological markers. So phenomenology of symptoms is one validator, but it's not enough. We can't rely just on symptoms, as we just said. What else can we rely on? Well, biological markers would be nice, but we don't really have many of those. Sometimes people like to use treatment response. That's non-specific, though, and not useful, which leaves us family history, genetics, and course of illness. Well, genetics is useful if you have a genetic disease, but what if your disease is not genetic? Then it's not useful. And that leaves us the course of illness as the only validator that can be used all the time to differentiate symptoms. Sometimes the symptoms happen at a certain age versus another age. They can be chronic versus episodic. They may get better or they may not. All these features become important in differentiating diseases. And that's essentially what Kreplin did 100 years ago. He said, look, you have these symptoms of psychosis, delusions, and hallucinations. Well, in one case, it begins early in life and it's chronic. In the other case, it begins early in life and it's episodic. The first one he called dementia precox, we kind of call schizophrenia. The second one he called manic depressive illness. And there was a third variety that was late age onset and chronic. And that's what they did find pathology there. And that's what we now call Alzheimer's disease. So, course of illness differentiates the two major diagnoses of psychiatry, schizophrenia and manic depressive illness, not symptoms. The genetics actually differentiate those two conditions too, because they are different in their genetics. So, validation means that you have a set of symptoms and you can show that their genetics and their course of illness, and sometimes biological markers, differentiate those set of symptoms from another set of symptoms. That's how you do it. If you don't have the genetics and course of illness and possibly biology, you don't know whether those symptoms actually are valid or not. So what I'm saying about DSM being mostly false is if you apply this criterion, which was established 50 years ago and is widely accepted as legitimate in psychiatric research, if you apply these validators, you either do not have evidence that DSM definitions are valid, or you have evidence that they're invalid for most of them, not all of them. That's why I don't say it's completely false. We'll see which ones. So this same group in the 1970s published a textbook, which you can still get, where they identified 10 diagnoses, as you can see listed here, 10 basic diagnostic categories. And I think this is true. I think there are probably about 10 valid diagnoses in psychiatry. That same group further studied those diagnoses and developed the criteria for them, which were called the Research Diagnostic Criteria, RDC. And they came up with 14 diagnoses, which you can see listed here. So maybe there's about 10 or a dozen valid diagnoses in psychiatry. You can see the list here. As of 1978, they felt that when they applied the validation criteria of genetics, course of illness, and biological markers, these 14 diagnoses could be separated out from each other. 14 diagnoses, 1978. 2 years later, DSM-3 is published. It has 292 diagnoses. Well, it wasn't the case that 270 diagnoses, or 278 diagnoses, I should say, were suddenly discovered in 2 years. They were literally made up by people sitting around tables. What they said is, what do people think? What's the consensus? What's the opinion of clinicians? What do we think is best for society? They took that pragmatic, utilitarian, social constructionist approach to the diagnoses. So if you accept that the RDC data as of 1978 were correct, let's just be liberal and accept them, then you could say 14 out of 292 diagnoses were valid in 1980 with DSM-3, and that's about 5%. In other words, DSM is 95% false by definition, by the way it was constructed. Now, it turns out that the RDC criteria, like some of these labels you don't use anymore, like Briquet's disorder, et cetera, some of these have actually not been validated. Generalized anxiety disorder has been shown to not be valid. So some of these are actually not valid, as I'm going to suggest major depressive disorder is not a valid diagnosis. So really, even the 14 isn't correct. Some of the diagnoses have been invalidated and therefore are false, but they're still in DSM. So at least 95% of DSM is false based on the way it was constructed to begin with and based on the fact that it continues to conclude invalid diagnoses. Now, the makers of DSM-3 knew this. They knew that they had made up 278 diagnoses, and they didn't deny it. What they said was, okay, this may not be true, but let's use it anyway, because let me jump forward. Let me go back. Let's use it anyway, because what this will give us, I'm going to actually take a minute here to type this. Actually, I can't type it. All right. What they said was what this will give us is reliability. And reliability means that we can agree on how we define things. And we can do research later and get more validity and get things better. Unfortunately, that didn't happen. And let me explain to you why it didn't happen. So with DSM-3, we have the science, which we just talked about. You have these validators of diagnosis and the attempt to say that we have reliability, we can get validity later. But there's a practice aspect to it too. Part of the reason DSM-3 happened, well, first it was the groups that were doing research on RDC that got the attention of the profession to some extent to say, hey, maybe we should redefine our diagnoses based on these validated definitions. But the second factor was a practice related one, which was the new drugs had come out. And these new drugs, the antipsychotics, antidepressants, and lithium, needed to be used with diagnoses that were not being used at the time in American psychiatry. And that is that American psychiatry was very Freudian and psychoanalytic. So it was using terms like neurosis and psychosis, but it was not using terms like manic depression and schizophrenia as much. And it didn't really define them the way Kreplin defined them. It defined them very psychoanalytically, involving unconscious emotions and childhood experiences. So many clinicians wanted to be able to use the drugs for depression, for mania, and for schizophrenia, which the FDA had approved them for. But those terms weren't well defined. So one reason DSM-3 got popular and was done is because it gave clinicians well-defined terms to be able to use these new classes of drugs. So even though DSM is not really directly related to drugs, psychopharmacology, and the pharmaceutical industry, a lot of people want to bring up, it is indirectly related because it was the rise of psychopharmacology that influenced the popularity of DSM-3 and the rise of DSM-3. Now, this had an impact because most of the American psychiatric profession was psychoanalytic and very Freudian, and they were unhappy when DSM-3 was coming about because they realized it was using phrases that were non-Freudian, and it was actually very anti-Freudian in some ways, in that it, for instance, it removed the phrase neurosis and the concept of neurotic depression, which was the most widely diagnosed type of depression in the US. It removed it and it replaced it with major depressive disorder. So psychoanalysts were unhappy. And one of the things that they did in order to allow DSM-3 to happen was they said, you know what? Okay, you've got your 14 diagnoses, but please add 200 of ours. Borderline personality, dependent personality, avoidant personality, schizoid personality, schizotypal personality, et cetera, et cetera, et cetera. just add ours in. And the DSM-3 task force, part of the reason you have 278 diagnoses added was they did that to compromise with the psychoanalytic community and give them diagnoses that they could use. Now, the psychoanalytic concepts, none of which are proven, most of which actually are disproven, but they were popular. The clinicians liked them. They practiced that way. Again, it comes back to being a social construction. The biopsychosocial model happened to come up around the same time and also gave a rationale for clinicians uh, to be able to use DSM concepts both for psychotherapy or for medications as they wished. So in a way, DSM-3 was a compromise between psychoanalysts in the US who had power at the time and the rising, more biological psychopharmacology approach. Keep in mind that the head of the APA, the presidents of the APA, the chairman of most of the departments of psychiatry in the US in the 1970s were psychoanalysts. And so the DSM-3 approach had to compromise with them. There were two successes and a failure of DSM. One success was that it did give reliability to some extent. It did give obvious definitions that people could agree on. The second success was that it ended the excessive power of Freudian psychoanalysis in the US when it got rid of neurosis, for instance, as a diagnostic concept. But its failure was it never achieved validation. And that's my critique of it now, and that's what we need to understand. What happened with DSM-4, 1994? You went from 278 diagnoses to around 365. Again, the diagnoses were made up, they were operationalized, they had reliability, and that's like having a dictionary. We can agree on our terms. Then we're going to validate them, make them better, and revise or delete them. But that didn't happen with DSM-4. DSM-4 was almost exactly the same as DSM-3. The diagnoses that were there were kept and a few more were added. Very little was changed in 14 years. That's because the dictionary became a Bible. A lot of people call DSM the Bible of psychiatry. Well, as you know, if you have a Bible, you worship it, you don't change it. Most of us in this, many of us on this Zoom meeting in Africa are going to be Muslims. So maybe the Bible isn't the best analogy. If you analogize it to almost like a Quran, it's the same concept. You take something and you worship it instead of anything else. It's actually unacceptable to change it. It's heresy to change the Quran. You can't change a word. You can't change a word of the Bible either, according to conservative Christians. And so you can't change a word of DSM-3, 4, or 5, according to mainstream psychiatry, because it's worshipped. And that's a very unscientific attitude. It might be fine for religion. It's not good for science. And this was actually stated with the DSM-4 transition. That's, I think, where DSM really went off the track, was DSM-4, not so much DSM-3, where the leadership said to the DSM-4 task force, they overtly told them not to make any changes, only minor ones and certainly no major ones. They essentially raised the scientific threshold for making changes. So you have all these changes in DSM-3 from prior beliefs that were based on very limited data. They've been kept now for 40, 50 years. And any further changes require huge amounts of data. And even then, they often are not accepted. The fact that this DSM conservatism has taken hold is something that dooms psychiatry from improving validity. In other words, the problem of DSM is not just a random problem, it's the central problem of psychiatry. We are doomed to not being able to progress scientifically in our field because we have a diagnostic system that's mostly false and we refuse to change it and we won't allow scientific data to change it. Let me give you an example. I want to focus on mood illnesses since that's my specialty. Before DSM-3, you had the concept of manic depressive illness, which was a very broad definition. And it included both people with depression and mania. There were two types of manic depressive illness: people who had manic and depressive episodes, who DSM-3 called bipolar, and people who only had depressive episodes that were called unipolar depression, but was not seen as a different illness. It's just the same illness with a different presentation. Manic depressive illness meant recurrent mood episodes of any kind, manic or depressive, not manic and depressive. So what you today call quote unquote major depressive disorder actually was manic depressive illness back then. Now, these unipolar depressive episodes were severe and they were episodic and they were recurrent. So again, recurrence was the key feature of manic depressive illness, not polarity. It didn't matter if the episodes were depressive or manic. In fact, they were usually mixed. They were both. That was Kreplin's view. That didn't matter. All that mattered is that they were episodes. They came and went. Recurrent mood episodes. That's what unipolar depression was. It was part of manic depressive illness. It responded to lithium just like bipolar. There really was no difference between the two. The genetics we now know are the same. But at the time in the 1970s, there were a few genetic studies that came out that claimed that they were different. That if you took people with mania, so-called bipolar illness, you would find family members with mania, so-called bipolar illness. And if you took people with recurrent unipolar depression, you would find family members with unipolar depression, but not mania. That's based on the genetics of the 1970s. That was the validating factor that led many people in the research groups like the RDC to differentiate out so-called major depressive disorder from bipolar. But in fact, we have had 50 years more research since then that's shown that there is no genetic difference. There's a lot of genetic overlap. If you look at the huge genome-wide association scans, they show that bipolar illness and so-called major depressive disorder overlap greatly. Well, if there's no genetic difference between the two, then they're not two different illnesses. They're the same illness because the validation is with the genetics. If the genetics are the same, you have the same illness. They're not different. So this distinction has been disproven, and yet this massively important distinction in diagnosis based on studies from the 1970s, which are false, is a core feature of DSM-3, 4, and 5. In addition to unipolar depression, they wanted to get rid of the concept of neurotic depression. So they included that in the same group, even though neurotic depression was a very different category before DSM-3 than unipolar depression. It was not episodic. It was not recurrent. It was not severe. It was mild, chronic depression, usually mixed with some anxiety. It was not genetic, unlike unipolar depression, which had a lot of mood illness in the family. Neurotic depression occurred in people without any mood illness in their family. It was not genetic. It differed, therefore, in its genetics and its course of illness, and yet it's been mixed into the same MDD category. Furthermore, there was another group that was called chronic involutional melancholia. These are people that had a different course of illness as well, with later age of onset. It turns out they might be similar to the groups that have in recent years been called vascular depression, which is age of onset 40 and later with white matter abnormalities on the MRI. There you have validation based on the course of illness and biological marker for one of the few times possibly in psychiatry. But this involutional melancholia, late age onset melancholia, which was chronic and late age of onset, therefore different from unipolar depression, which was early age of onset and episodic. This group was also included in the MDD category. So what DSM-3 essentially did is it took many different varieties of depression and it mixed them together into one in an invalid way, ignoring actually the genetics and the course of illness validators, at least in the recent years. One person whose research was used for this was Jules Angst in his Zurich study. His research was some of the research from the 70s, which suggested a difference between genetics and course between bipolar and unipolar subjects. But his own same research later found that there was no difference in the course of illness. And even in the genetics, there were less differences. So his research was used to create DSM-3, but his same research was rejected by DSM-4 and 5 because it contradicted what they had already decided with DSM-3. So this is a good example of showing how science is rejected in the DSM process in terms of future validation. This is the best example because it's literally the same research project that was used in DSM-3 but rejected for 4 and 5 because they just didn't want to make the changes. More and more data are needed for smaller and smaller changes, and that's how the DSM process is becoming less and less scientific. Instead, you have this pragmatism, which is based on a postmodernism, which is based on a relativism about truth, which is based on a social constructionist approach to diagnosis, and therefore and rejects science essentially as either arbitrary or unnecessary. This is a philosophy that's behind the DSM system, and it blocks scientific progress for our field. You see this with research on biology and pharmacology and genetics. There have been 30, 40 years of studies using DSM definitions that have failed to find genetic uh, causes in any clear way for anything, and that have failed to have pharmacological mechanisms that produce strong benefits for patients. And that's because pharmacology and genetics does not follow social construction. Pharmacology and genetics does not follow what a group of American psychiatrists decide sitting around a committee table about what they think is best for them and their profession and for American society. I should add about this pragmatism. I really don't understand why you, as psychiatrists in Sudan and Egypt and the Middle East and Africa, should care what the Americans think about psychiatric diagnosis. Why should you do what Americans created for American patients and American doctors? They never said that they intended it for the whole world. But actually, what happened was the Europeans accepted the American system and took it there. But really, there's no reason why any other country should decide. This would be like if the Sudanese Psychiatric Association decided to come up with its own diagnostic criteria, and then all the Americans had to follow what the Sudanese decided. Why should they do that? Well, why should you follow the Americans? I've never understood why the whole world decides that it's okay to follow American psychiatric definitions just because it's American. And yet everyone is quite willing to criticize the United States on politics, on religion, on many other social and cultural issues. But in psychiatry, everybody accepts it without thinking. There's no reason for that because this is an American social construction. It's not anything based on science with any universal legitimacy. Well, even the US National Institute of Mental Health decided with the fifth edition of DSM in 2013 that this had gone too far. At that point, after about 30 some years of repeatedly failed studies, the National Institute of Mental Health said that they would never use, that they would stop using DSM criteria for research grants in biology, pharmacology, genetics, and such. Before that time, for the prior 30 years, you could not get an NIMH grant unless you use DSM criteria. Now the NIMH was saying, we will refuse your grants if you use DSM criteria, which goes to show you how unscientific DSM criteria are. However, the Food and Drug Administration that approves drugs to come to the market still uses DSM criteria. You might ask the question, if the criteria are not based on science and now accepted by the main US scientific agency as not being legitimate for research, why are they good enough for the pharmaceutical industry and for the government regulatory agencies for drugs, like the FDA? Why are they good enough for use for medications, for the way we define what medications should come to the market and what they should be used for? If you ask that question, you'll realize that we have a problem where medications are coming to the market for unscientific reasons, and yet they're being used widely by clinicians. Now, so there are some cynics out there who will say, that just follow the money, that DSM is all about economics, and that's not totally irrelevant. I'm showing you this number of $250 million because basically DSM-5 produces $250 million for the APA. Each year, it produces about $36 million for the APA budget, which overall is about $50 million. and that means it's about 2/3 of the APA budget. And you'll notice that the APA has zero money from the pharmaceutical industry. It used to get money from them, but it was criticized for that, and it's replaced that with DSM. Without DSM, the APA budget would not be workable. Just to give you a sense of this, DSM-3, the third edition, produced $600,000 a year. DSM-4, oh, yeah, DSM-4 about 1 million. DSM-5 is over 1 million a year, but it really adds up to much more than that. To have a context that there are 40,000 psychiatrists in the US and 300,000 mental health professionals, and almost every single one of them buys a copy of the DSM. So it guarantees you, with a price that's high of $170, a lot of money. We're talking hundreds of millions of dollars. So besides all the scientific critique I'm making, there is an economic reason why the APA, the American Psychiatric Association, is so conservative about DSM and so protective of it. It relies on it for majority of its funding. If the DSM were taken away, there would need to be a big change there. This is an important point. So let's go forward on a few concept issues. There are things you can see listed here that are worth talking about in more detail in a different setting about how DSM has influenced conceptual thinking in psychiatry. The DSM claims to be atheoretical, therefore it uses the phrase disorder, which is meant to be vague and meaningless on purpose. Sometimes people interpret the concept of disorder as a disease, and sometimes they don't. It doesn't mean either one. It could be a disease, it might not be, but the term disorder doesn't make a commitment. In medicine, we use disease phrases and we use non-disease phrases. And I think it's important in psychiatry for us to use other phrases. I refuse to use the term disorder, for instance. Another thing about DSM conceptually that's really important is that every quote unquote disorder is defined based on having severe symptoms plus functional impairment. Well, in medicine, that's not the case. In medicine, we will diagnose cancer even if you have mild symptoms, even if you have no functional impairment. We diagnose hypertension and hypercholesterolemia without any symptoms at all. It doesn't make sense to refuse to diagnose a disease or the precursors of a disease just because the symptoms are mild or because there's no functional impairment. But that's what we do in psychiatry. And that's another example of how DSM is anti-medical and not a medical model at all. DSM is unscientific and it's anti-medical, contrary to the popular beliefs that people think it's very research-oriented and medical model. It actually blocks research and refuses to use research, and it's not using medical approaches to diagnosis. Unscientific, unmedical. We could get into this more, but in the interest of time, I'm going to move along. And let me see what else I want to point out. Yeah, so this point is worth making. The issue of comorbidity in DSM is also relevant, where many diagnoses are made, and that's because it's fully based on symptoms. As we know, symptoms have lots of overlap with each other, and therefore you say someone has generalized anxiety disorder, MDD, major depressive disorder, and ADD, attention deficit disorder, when in fact all they really have is cyclothymia, and that's not getting diagnosed at all. Instead, we should be applying a hierarchy of diagnosis. This is one example that mood conditions can cause psychotic, anxiety, and attentional and personality changes. That doesn't mean that when you have bipolar, you also have ADD, GAD, and borderline personality. But that's the way we define things with DSM, where a concept of a hierarchy is explicitly rejected. Again, in the rest of medicine, this is not the case. The medical approach is to create a differential diagnosis and to diagnose as few diagnoses as possible that can contain within them as many symptoms as possible. Now, you don't need to know the etiology or the cause. Many people, when I bring this up, say, but we don't know the causes of these conditions. Well, you don't need to know the cause. That's not necessary in medicine either. We often don't know the causes. We don't know the causes of diabetes, high cholesterol, and hypertension, yet we can make those diagnoses. So you can have a hierarchy just based on some diagnoses causing more symptoms than others, and they need to be ruled out before those other symptoms are diagnosed. It's unmedical and unscientific to say when you have a pneumonia that you also have comorbid fever disorder. In the same way, it's unmedical and unscientific to say that when you have bipolar illness, you also have comorbid ADD. The inattention is the cause by the mania and the depression, just like the fever is caused by the pneumonia. There's no comorbidity. When you take this approach, you diagnose patients with fewer diagnoses, and you also give them fewer medications. So the postmodernist, social constructionist comorbidity approach of DSM also leads to polypharmacy, with many medications given for many symptoms, which causes lots of side effects and limited benefit. Let me go forward. I'm going to just focus on validity and reliability, and then I'll stop. The key claim I'm making in this lecture is that DSM is mostly not valid, 95% to be exact, at least. And an example of this in DSM-5 is that the personality disorders were shown to be mostly invalid based on the scientific research. This was actually reviewed by the DSM-5 Personality Task Force. They were going to drop 6 out of 8 of the diagnoses. They were only going to leave borderline and antisocial. And they were going to replace them with personality traits, which have been scientifically validated very well. But because of a letter writing campaign led by many psychoanalytically oriented clinicians who like diagnoses like narcissism and such, the APA Board of Trustees actually vetoed the DSM-5 Personality Disorder Task Force at the last minute, a few weeks before the publication. And the personality disorders were left unchanged since they've been in 1980. And again, in 1980, they said they were literally making it up based on just opinion, and that in future revisions, they could validate and change the criteria. And here we are 40 years later, and the DSM-5 task force actually tried to do that. And the APA, as a professional organization, refused to allow it to do that. This is a very clear example of how the DSM process is unscientific and therefore harmful. We had reliability, at least I said. Well, actually, it turns out it's not even very reliable. The DSM-5 field trials found that if you look at reliability, the majority of the diagnoses are not much more reliable than flipping a coin. The kappa value of 0.5 is flipping a coin. Generally, a kappa value of 0.6 and above is good. In DSM-4/5, they had a lower criterion of 0.4. But even applying that lower criterion, only 1 of 15 diagnoses had acceptable kappas, and that was alcoholism. Take major depressive disorder, its kappa value was 0.23, which is a decline from DSM-3 in 1980 when it was 0.5. That means that clinicians disagree about 80% of the time on, and even something as straightforward, apparently straightforward, as whether someone has clinical depression. In other words, validity has not been established with DSM-4 and 5. It's actually declined. And reliability has also declined with DSM-4 and 5. So there isn't even that aspect where we could say DSM is helpful. So let me finish by just speaking to you for a minute about what would be a better alternative. I'll give you one simple one, and that is what one might call clinical research diagnostic criteria. That is, going back to the research diagnostic criteria concept of the 1970s, basing it on clinical research, not the research domain criteria of the NIMH, the so-called RDoC, which is based on biological markers like neuroimaging, but clinical signs and symptoms, course of illness, genetics, and biological markers if you have it. I'm just saying, let's go back to what everyone has said is acceptable from the 1970s and apply that concept of clinical research diagnostic criteria for validation of diagnoses. When we've done that for bipolar illness. We published a paper on that a year or two ago, and that could be done for schizophrenia and for all the other major illnesses by researchers. And I would suggest that we could have 10 or so diagnoses that the research experts in those conditions could validate and give you clinical research diagnostic criteria. And that's all we need. There are only about 10 valid diagnoses in psychiatry. Things like bipolar, manic depressive illness. I wouldn't say bipolar because I think unipolar and bipolar are the same. Manic depressive illness, neurotic depression, schizophrenia, OCD, autism, post-traumatic stress, maybe borderline personality, maybe antisocial personality appropriately defined. You could list about 10 or 12 of these conditions and give validated research-based definitions for them. And then everything else, all the other issues that people have, all the other ideas and opinions that people have, well, clinicians could have those opinions, but we don't need to define them in a way that we want to force the whole world to diagnose only one way. And let the world of science and research have its debates, and future diagnoses that get validated over time can be added to our repertoire. This should be the process that happens in journals and in textbooks, and maybe with research groups providing research criteria. That's what the rest of medicine does, and that's what I think we should do. We need to be more medical and scientific. DSM is unmedical and unscientific. Thanks for your attention, and if we have some questions, comments, maybe we can have a discussion.
Thank you very much, Dr. Ghaemi, for this really interesting topic and presentation. I'll open, the questions here, and I think we have a couple of questions in the chat here. There's a question from Dr. Ahmed here. How do we avoid many drugs approved based on the DSM labels and concepts? For example, FDA and many of the following regulatory bodies, like they require FDA requires basically DSM diagnostic criteria in order to put an approval.
Well, I published a psychopharmacology textbook where I describe how we can use medications in a non-DSM way. So you can easily avoid it. The fact that the FDA brings drugs to the market for DSM labels doesn't mean that you have to use it for DSM labels. So for instance, if we reject major depressive disorder as a legitimate concept and we use mixed depression as a better concept, we would use dopamine blockers, so-called antipsychotics for mixed states, irrespective of what the FDA says. Who cares what the FDA says? You might say, okay, but I'm just a practitioner, I'm not a professor or whatever, I'll get sued. Okay, be careful, be careful. But still, you are not forced to practice the way the FDA labels things. The FDA actually is quite open about that. The FDA labels are only to get a drug onto the market. Once they are on the market, physicians can do whatever they want, as long as they have a good clinical and scientific rationale for it. You just have to explain that in your notes. There's tons of research on mixed states. So you could say, I'm using this dopamine blocker for mixed depression, and here's the reference from Ghaemi or Koukopoulos or whoever. And you would be ethically and legally protected if you did that.
Another question here is making about a comparison between the ICD and DSM on their scientific base. Which do you think is more accurate?
They're both false. And the reason is, unfortunately, the European ICD system is just what the Europeans do is they just wait for the DSM revision and then they adjust their ICD to the DSM revisions. They do that consciously. They meet with the DSM leaders and they make sure that there's a correlation between their criteria. So the ICD is just DSM, it's a DSM. It's nothing different.
Another question from Dr. Abdul Ghani. He's asking also about the same thing, about how we're basing, like we don't have laboratory or radiological aid for diagnosis, and hence we're depending on diagnostic criteria here. And the question is, what about this, whether this ICD is also almost false? The second, if the DSM is mostly false, then what is the solution? Shall everybody, every one of us diagnose according to his own assessment and label the patient with new diagnosis, not mentioned in the classification system? What would be the alternative?
Well, I gave you the alternative, but let me say it again. What does a dermatologist do? What does a cardiologist do? What does an infectious disease specialist do? Why are we even asking this question? I'm really shocked all the time when a psychiatrist asks me this question. What's the alternative DSM? What's wrong with us? The rest of medicine doesn't even ask the question. What do you tell me what the answer is? Isn't it obvious? You need people to tell you how to diagnose every single thing. Don't you have any knowledge clinically based on your own education and your own practice? And it isn't that yours is, Yasser, yours isn't going to be different than me. It shouldn't be on every little thing. I mean, we've all read the same textbooks. We've all seen the same kinds of patients. We're not stupid. We're intelligent people. See, one of the things about this whole DSM system too is the DSM leaders mistrust clinicians. They think clinicians are stupid and that they need to be told on every single point exactly how to do things because they're dumb. Either they're dumb or they're unreliable, they're untrustworthy, they're going to do crazy things. It's really disrespectful of psychiatrists. So I don't think we're so stupid that we're going to go back to 1935 and have a gazillion different ideas. It's really unnecessary to think this way. So, firstly, I think you should have much more confidence in yourself. And I'm sure that every one of you will diagnose patients accurately based on standard diagnostic concepts in psychiatry that you can read in the major textbooks. Secondly, research diagnostic criteria would guide you for the 10 to 12 major diagnoses that matter the most, where we have the most data. I think that's the answer to that. Remember the first question, ICD is the same thing as DSM. The ICD bureaucrats at the WHO sit down with the APA bureaucrats in Washington, D.C., and they create the same things. They look at their criteria, they write the same things down. It's not different. They actually coordinate it with each other. But it is driven by the APA and DSM. What DSM makes a change, ICD follows. So the place to make the change is either to get rid of DSM in the US or for the Europeans to sit around to finally say, we reject DSM and we're going to have different criteria. But they actually don't do that.
Another question here in your example about personality traits versus disorder. Why do you say that traits have been shown to be scientific, but disorders based on these traits are not?
The disorders are not based on these traits. And it's a simple fact that the traits are shown to be scientific. All you have to do is go to the scientific journals. It's not me saying something. I'm just stating the truth. If you just look at the scientific literature, the DSM-5 Personality Disorder Task Force published a number of papers where they reviewed these studies showing the evidence for validity. So you can go to that to look for it. But you should spend the time instead of asking this question, you should go to Google Scholar and read about 100 papers on the validation of personality traits, and you'll see it's not about me saying it or anyone else saying it. It's all out there. DSM disorders, quote unquote, disorders, personality are not based on personality traits. Personality traits is in the empirical experimental psychology literature. DSM personality disorders is based on psychoanalytic constructs from the 1970s. It's not based on personality traits. And those psychoanalytic constructs have never been proven to be valid. In fact, as I said, 6 of them have been disproven based on the validation criteria I gave you.
Another question talking about the current views about the DSM and whether many people are started to believe that the DSM and the current views about the DSM and people not believing about the current about the basis and the how false the DSM is. How is that kind of being currently held in the US?
No, I mean the view that I'm expressing is my view, and it's not the view of 99.9% of others, I guess, among American psychiatry. Certainly not the APA leadership. There are many people that criticize DSM outside of psychiatry. I don't agree with them either. I disagree with mainstream American psychiatry on DSM in our profession, but I also disagree with their critics because they're criticizing DSM from a postmodernist perspective. Their view is that DSM is a medical model and research based, and it should be much more socially constructionistic, and accept that DSM labels and psychiatric labels really aren't legitimate diseases, but are just ways that society controls people who are different. That's some of the postmodernist critique. I disagree with that. For all the reasons I gave you, DSM is not medical and research based at all. So my problem with DSM is not that it labels people who it shouldn't. My problem is that it's just unscientific and its labels are meaningless and that we should do it more scientifically correct.
Right. Actually, next question is going to be mine, actually, which is basically the whole idea about the DSM, which is basically theoretical, does not have a reference for comparison to begin with. It's just we're talking about operationalism. We just choose a criteria we can generalize, and this is exactly where we achieve consensus. How can you take the course of the illness, which is an important factor that Kriplin has shared, like to differentiate A from B, to differentiate manic depressive insanity from dementia precox? The course of the illness was a major contributing factor to do this. And you have this shared with other medical presentation or psychiatric presentation. Movement disorders on the face, they look the same. is the course of the illness and the presentation and how how the illness, like the movement progress, is an important factor to differentiate A from B. How can you contain this in future criteria without affecting the it will guess it's going to mess up significantly with the reliability.
Well, the reliability is already terrible, so it's bad. So how is it going to make it worse? I mean, why do we even need criteria?
Research.
When you talk to a neurologist and say, "Hey, how do you differentiate Huntington's disease from Parkinsonism?" Does he say, "Well, there's 3 criteria out of 7, and we take 5 out of 6, and this one's 4 out of 7"? You don't need to do that. Just be a good clinician. You have very basic concepts and you apply them.
Let me check if there is any more questions, and we can end.
I don't know if that responded to your comment. Yes.
No, to me, for sure. Like, I mean, I cannot. Like, I mean, this is exactly what I even teach my students and residents. The course of the illness is really important, differentiating A from B, and without it, basically, symptoms are symptoms. They mean nothing.
Absolutely.
Without context, they don't exist
Right.
without context. They don't mean anything without context.
Right. But your point was what? That if you start applying course of illness, you'll get less reliability, or?
I mean, because if we want to do a research, if we want to do a study, how can you include this to differentiate A from B? Which you might need some, like, you want to include this because it's important. It's an important factor to differentiate symptoms like of in psychiatry, but you can include this in the criteria for research.
Yeah, you can. There's no reason why you can't. We already do. Schizophrenia has a course criterion. It's one of the few examples it does. You have to have chronic symptoms for 6 months or longer. It's not hard to do that. So no, it's just a matter of, I don't think it's a problem at all. In fact, it makes it better. I think we should include genetics as criteria. If we have criteria, like I said, I don't think we have to be so focused on that, but if we do, yeah, I think it's, remember with reliability is not more important than validity. You can describe something very reliably, but it could be completely false. So I say the unicorn is in the dictionary, but there's no such thing as a unicorn in the world. So we shouldn't say that reliability is going to get worse, therefore we shouldn't do this. No, validity matters too. And validity actually matters more, because if what we're talking about doesn't exist, it's a waste of time. I think we have his question on the chat that was worth getting into. And I think this kind of probably agrees with what a lot of people are wondering. How do we incorporate these concepts into practice? And then you can give examples. So I think the way we incorporate this into practice is to say that we don't use DSM criteria for making clinical decisions. You may need to know the DSM criteria for your insurance billing in the US, that's relevant. So if I diagnose somebody with a unipolar depression with mixed states, that's not a DSM criterion, DSM concept. But on my billing form, I just check major depressive disorder. I use it for the billing form, but I don't think about it at all. I don't use it to make any decisions about medications. I don't use it to teach. In other words, the DSM criteria can be used when you have to in an insurance setting, or if you're having some other scenario where it has to come up. But in practice, when you're saying, what's the patient's problem and what should I do for it? You don't have to use DSM concepts at all. You can use non-DSM concepts. Just, for instance, mixed depression, mixed states is well established in scientific studies. Mood temperaments, cyclothymia, hyperthymia, and dysthymia are very important. And patients falsely get diagnosed with GAD, MDD, ADD. I diagnose a non-DSM concepts, not in DSM, hyperthymia. In some of these patients, I give them low-dose lithium and they do great, or low-dose Depakote. So basically, you can ignore the DSM concepts when you are aware of other concepts that are more scientifically legitimate, which means you cannot be a good clinician if all you know is DSM and then the drugs for it. That's the way most people practice. That's why patients are doing so poorly. That's why our mental health system does not actually meet the needs of our patients. They're doing badly because our system is incorrect. But that does mean that you have to do extra effort to read the scientific literature, go to conferences, hear about other ways of thinking, and use those approaches instead. As I said, I've written a textbook which lays it all out for you if you like. That could be all you need, for instance. Or webinars and things like that. You know, those who attend some of our webinars psychiatryletter.com is where we have webinars. That's a place where we talk about how to do this. There is teaching that's needed. There's not a lot of it. I'm trying to do it. There are a few other people, but this other approach can be taken to change practice.
All right. I think this takes us to the end of our presentation today. Thank you very much, Dr. Ghaemi, for this really interesting presentation and for being here today.
Thank you. Yes.
All right.